smallest cranial nerve and tell me what you know about the cause of number 4. Only nerve coming from the dorsal aspect. What else? I didn't hear that. It's very fine. Where exactly does it leave the... Where is this nucleus? I don't know. I'm going to try and see if I can... This thing only has about 3,400 fibers inside it. It's very small. Whereas the oculomotor has over, over 24,000. This thing is very small. It's kind of difficult to put a... I can see it, but okay. You see that little thing behind there, man? This little fine thing, that's it. Like coconut fiber. Coconut fiber, very fine. Yes. So it's very, that little thing you see wrapped up behind there. Right. So I'm happy we have the projection that can show us. Right. So it's very small, coming from the level of the inferior colliculus. But when it comes out, it's coming below the frenulum villi, which is a little bit below the level of the superior colliculus. Yeah. The frenulum villi, V-E-L-I. It's just a little area below the superior colliculus. Yes. And it will then, remember, and again before it comes out, it decussates. It decussates. So it's dorsal, it decussates, it's decimated, and what else? It supplies the superior oblique on the dorsal aspect. And it is the only cranial nerve motor outside of the annular ring of Zinn. Alright? You got that? Yes. Annulus rung. Okay. So it's going to leave the frenulum villi, having decussated, come around on the side of the brainstem, run between which two arteries, posterior cerebral and superior cerebellar, right? Run forward in the vicinity of the interpeduncular fossa and run towards where? Cavernous sinus. In the cavernous sinus, it's going to take a kind of lateral position, right? And then it is going to shoot through the superior orbital fissure, but it's going to run outside of the annulus. And it will going to approach the superior oblique from its dorsal aspect and supply it. Superior oblique, what's the function of superior oblique? Down and out. Alright. So, a patient lives upstairs. A patient lives upstairs. What trouble will he have? He'll have trouble going upstairs or going downstairs? No, not upstairs. He's going to have trouble going downstairs because he needs to look down. And he needs to look on this side too. So he's going to have trouble going downstairs if he has a superior oblique lesion. Superior oblique gives us a down and out, right? The inferior oblique gives us up and out, right? Right. Why do they work in that way, table 1?
because of how alright, the superior oblique is like it's coming from as in
the trachea.
the trachea. Yeah, so it goes around the trachea and then it insert like so those is posterior to the coronal
equator. Right, behind the equator. And the same thing for an inferior oblique, it's inserting behind the equator.
But
so they're
about the intorsion and extorsion, I don't understand that part.
The intorsion and the extorsion, think of it as a kind of a rotation around an AP axis. A rotation around an AP axis. So you don't get that. You get the AP axis.
Yeah, I get it.
Good. And you are superior. You have a ball. And your hand is on the top of the ball. And you're pulling the ball towards the midline. But it can't pull. What you do, you'll spin it. So the 12 o'clock position is going to be pulled to like 11 o'clock. So the superiors are going to cause an intorsion, whereas the inferiors will cause an 12 o'clock to go to 1 o'clock. So the inferiors will cause an extorsion, whereas the superiors will cause an intorsion.
That is when you are looking at the person, or you are just imagining that you are using.
You are looking at the person. You are looking at the patient is looking at you, yeah. Doctor. Patient is looking at doctor, right? And the patient has a trachea which is inserted on the medial side, yeah. Superiorly. Good. So when that superior muscle contracts, remember the superior muscle is on the superior aspect of the thing. And on the AP axis, the insertion point is on the lateral side. So when it rotates, it's going to bring it medially. Right. So it is going to cause an intorsion. 12 o'clock will go to 1 o'clock. Superiors will cause an intorsion. Yeah. All right, take a look at this. Let us view this. All right. You can make out this little black spot here. All right. Good. So this is where the trachea is. And the trachea is on the superior part of the orbit. All right. And the insertion is beyond, the insertion is lateral. So when it pulls, it is going to pull the thing towards the midline. Yeah, it's going to pull, so 12 o'clock is going to go towards 1 o'clock. Right, so that is going to be intorsion. So the superior causes an intorsion. Right. You agree? You can see that part? The superiors coming from a superior aspect, going posterolaterally. When that contracts, you're going to roll the ball inwards. So 12 o'clock is going to be pulled over to 1 o'clock. That's intorsion. No. It's rolling. The ball is rolling. The eye is a ball. Think of it as a ball. When we are doing an intorsion, we are rolling on the AP axis. the AP axis is going through. When you roll clockwise, that's intorsion. If you roll the other way, that's extorsion. So if you're going from 12 to 11, going back to 11 o'clock, that's extorsion. If you're going from 12 to 1 o'clock, right-handed screw, that is intorsion. And because the superior oblique is at the level of the trochlea on the medial side, when it pulls, the ball will have to spin towards that side. The ball will have to spin towards the midline. That is intorsion. The superiors can't do anything but cause an intorsion. On the other hand, the inferior oblique is coming from the bottom on the medial aspect and going back posterolateral. So when it pulls, you're going to rotate the thing left-handed way. That is extorsion. So remember, intorsion is a rotation on an AP axis. I think if you get it, that the axis, all of these things with the movement, the eye has 3 axes. So intorsion and extorsion, they occur on the AP axis. Once you have that, then you know how to roll the ball. Yes. I am trying to make it as simple as I can, but if you're not getting it, it is very important that you understand it as a rotation. It's not an abduction. It's not an abduction, it's a rotation. Intorsion is a torsion, is a spinning. Is a spinning, yes. It's very important that you get that aspect. It has to be a spinning aspect. Otherwise you're going to pull it. And if you pull it, you're going to get abduction. Sorry, adduction. But you don't want that. It's a rotation. Yes. So where 12 is in the midline, it's going to spin towards 1 o'clock. If you spin towards 1 o'clock, you're rotating on an AP axis. And that's an intorsion. Right. You get that?
So if you go home and sit and relax and read your art last.
It takes a little thinking. It don't feel any weight. Right. It gives people trouble, so don't feel any way about it. It needs some thinking. It's where you're going to go back to your physics, and you won't be able to work it out. What?
This is superior. You're talking about rectus, right? Superior oblique. Superior oblique. This is it, right? When this pulls, it will be pulling this way. Which way the eye will rotate?
Rotate like.
Alright. So that was number 4, eh? Number 5. Okay. Let's go to number 5. Number 5 is the